Hello, welcome everyone, wherever you're joining us for today's webinar. My name's Alexander Love, and I'm a Senior Editor for Global Data. We're very pleased to have you attend today to discuss the topic Real-World Data, a tool for vaccine outreach and education. I'd like to welcome you to our webinar platform. This webinar is browser-based, so if you disconnect at any point, please click the link you received via email to rejoin the session. If you'd like to ask a question, you can do so using the Q&A widget on the platform. We'll try and get through as many of your questions as we can once the discussion has ended. Please use the help widget if you experience any technical difficulties or require any more assistance. And you can also use the related content box to access any additional resources. Today's webinar is brought to you by MarketScan. I would now like to hand you over to Lisa Palmer.
Thank you, Alex. Before we get started, we'll do some introductions of the speakers today. My name is Lisa Palmer, and I am a portfolio leader with the Real World team here, specifically with the research and analytics team. I am a health services researcher by training, and I have worked in the real world data, real world evidence space now for more than a decade. And I'm excited to talk with you today. I'll hand it over to you, Megan.
Good morning or afternoon, wherever you are. My name is Megan Richards, and I am a researcher in the same group as Lisa at Merative. I am a trained epidemiologist, and I look forward to presenting for you all today.
And my name is Brenna Brady. I am a practice leader in the same group as everybody else. I am a bench researcher by training, specifically a PhD in immunology, but I've been in the health outcomes research space for about a decade now. So I'm going to go ahead and kick us off, and we're going to really start with a sort of brief social history of vaccination. We're going to start all the way back in the pre-vaccine era, which certainly goes back to at least the 15th century, but realistically, it probably goes back longer. And the focus here from a disease space was really around smallpox. It was the major disease of the day, and people were predominantly dealing with it through the process of variolation or inoculation, same concept. But basically the way that this worked is you would find somebody who has an active smallpox infection. In the case of smallpox, this is going to be somebody with pustules all over their body. You are then going to take the pus out of them. You're going to inject it into yourself. And after that, you're going to really hope that you don't die of smallpox. If you survive and you don't die of smallpox, there's a really good chance that you're going to be immune to smallpox for the rest of your life. And this whole process was really worth it at the time to a large proportion of people. There were certain areas where this is something that, really kind of took off and was common, other areas less so. But this was the predominant way of fighting smallpox back before the current vaccine era. And we'd kind of say the current vaccine era starts in the late 1700s. Usually it's associated with Edward Jenner. He's an English countryside physician, and he realizes that people, milkmaids specifically, who frequently come into contact with cowpox, don't seem to be getting smallpox at the same rate as the remainder of the population. So he runs this experiment where he finds a small boy in rural England and a milkmaid with an active cowpox infection, and he inoculates the boy with cowpox. Boy gets sick, but he recovers. The difference from what Jenner does between that and the pre-vaccine era is that after the boy recovers, he actually comes back a month later and injects him with smallpox. And what we learn is that the boy is now largely immune to smallpox. And this sort of ushers in what we would consider the current vaccine era, or the current concept of vaccination, where your exposure to a less virulent form of a pathogen is able to protect you from the disease that you're really trying to protect against. So in this case, smallpox. This is really considered a massive success by Jenner, but he basically spends the remainder of his life trying to convince everybody else that this vaccination, inoculation, is a really positive thing. And he does succeed, and other vaccines are coming up over time, and there's a lot of research into the space. But we're kind of moving on. It does take place in the mid-1800s in the US, that the concept of vaccination as a whole has caught on so well that Massachusetts institutes the first sort of school vaccination mandate for smallpox. So this is maybe, one of the first places in the US that we're seeing this combination of public health through the concept of herd immunity. I'm not sure it would have been called herd immunity back then, but public health and the regulation of vaccination and the regulation of public health through legislation. Moving forward into the World War I era, we start to get into other vaccines. The pertussis vaccine comes out. And then at the end of World War I, we hit the Spanish flu pandemic. And this has a massive impact globally from a mortality perspective, but it also influences troop movements in World War I. So coming back from World War I, the US government is really realizing that, this is not okay. The impact of troop movements is not going to work for us long term. And they stand up a program to develop a flu vaccine at the end of that, to try to mitigate any sort of future issues with disease and war. That vaccine does come to fruition about 30 years later at the end of World War II, and is then quickly released to the general populace as one of the first flu vaccines available. That kind of brings us down to this middle row, which I'm going to go ahead and call the vaccine boom in America. And, we start in post-war America. We're starting to get more vaccines. We get diphtheria, we get tetanus. We kind of combine that with pertussis to do the DPT vaccine. We're also starting to see some benefits of early vaccination campaigns around smallpox, with the last case of smallpox in the US. So this demonstration that vaccination works certainly takes some time, but certainly works. As we move into the early 50s, in 1952, the United States has the largest polio outbreak to date. So it's fair to say that by the time the Salk polio vaccine came around in 1955, America was very much ready for this option. It's really taken up by the populace. The government at the same time kind of forms this partnership with the medical community in some ways. And they have the Polio Vaccination Act that is instituted in the same year. And that's really aimed at getting the polio vaccine out to the general populace through standing up vaccination, statewide vaccination programs and things of that nature. And then through the early 60s, even into the 70s, we kind of continue this medical governmental partnership between the development of more vaccines. You can see we get the Sabin oral polio vaccine, measles, mumps, rubella, MMR into the early 70s. But at the same time, there's a series of legislative things that are being rolled out. The Vaccination Assistance Act in 1962, so sort of an expansion of that Polio Vaccination Assistance Act that we saw from 55. There's the Federal Immunization Grant Program, where the US government is actually buying up vaccines and delivering them to states to make sure that people are fully covered. The ACIP is established in 1964. I think it's also relevant to point out that although there is generally this really positive feeling around vaccines and vaccination and this partnership between medical and government, it's not absolute. Very few things in life are absolute. And you can see that back in 1961, we actually have California being the first state to allow a personal belief exception for vaccination. And this is a concept that is certainly going to come up later in this presentation. Moving into the late 70s, early 80s, we're still kind of in this partnership phase. We're still getting more vaccines. The National Childhood Immunization Initiative comes up in 1977. And this is really just a goal to say that, we do want to maintain herd immunity. We want to get all childhood vaccinations up to 90% of the population covered so that we can protect widely the population at large. In the late 70s, early 80s, we are starting to see even more benefits of the vaccination programs that have taken place. So in 1979, we see the last wild polio virus infection in the United States. And we're really talking about 30, 40 years after the start of the polio vaccine. So big benefit there in the US. And then in 1980, we see the global eradication of smallpox, which is in some ways extremely impressive if you consider that we're in the middle of the Cold War at that time between the Western and Soviet powers. So there's a place where things really came together in a way that they maybe weren't from a global perspective, politically or economically. We kind of roll out the rest of the 80s or at least the early 80s, with the development of a couple of other vaccines, bringing us down into this lower road that I'm going to go ahead and start to call a vaccine recession era. And that kind of starts with the National Vaccine Program, which is aimed at really just coordinating vaccine research in the US. That's great. That also comes with the National Childhood Vaccine Injury Act. And this is a governmental response to some things that happened with the whole cell pertussis vaccine in the late 70s into the 80s. And there were some things that came out that were linking incorrectly, but were linking the pertussis vaccine to adverse events in children. It turns out to be childhood epilepsy, but the narrative that the vaccine was causing brain damage came out. As we, I think, all know now, that's a very hard thing to combat. And as a result, parents started suing pharmaceutical companies over these adverse events, not actually adverse events, but over these perceived adverse events. And the pharmaceutical companies started realizing that their margins on vaccines were not nearly large enough to really have to deal with this risk. And they stopped making vaccines, leading to just a glut of vaccines, a shortage of vaccines in the US in the mid-'80s. So the government steps in with the National Childhood Vaccine Injury Act to indemnify the pharmaceutical makers against lawsuits from the general public. And I would say this is certainly not the hard start to this recession idea, but it is a time where we're starting to see that, maybe people are not necessarily all in on vaccines in the same way that they were in post-war America. You will also kind of consider that we're starting to see the birth of the internet at this point. Now, we're not going to really hit the internet fully for a while yet, but that's going to allow individuals access to wide availability of data from a wide availability of a wide group of data creators, not necessarily medical experts. So we're going to see that come up. We're also starting to see probably a little bit of vaccine fatigue. You can see all these purple dots in the middle. A lot of vaccines have been developed over the last 20 or 30 years, so people may potentially be getting a little tired of that. And then there also is kind of a shift from a societal focus to more of an individualistic focus. But at any rate, we kind of roll into the early 90s with, again, some benefits. We're getting rid of poliovirus in the West. We have a couple of other vaccines come up. In 1988, there's a new rotavirus vaccine that comes up, but it's withdrawn a year later due to gastrointestinal side effects. So again, maybe not the biggest win for the pro-vaccine argument. In 1999, there's the publication of what I would say is the now infamous paper linking autism to the MMR vaccine. That is obviously later debunked, but that comes out and really starts a whole narrative around that. We do have some early wins in the early 2000s with the elimination of measles, the eradication of rubella. We see some more vaccines come up. In the late 2010, early 2010s, we hit the H1N1 pandemic. And at this point, the US government does actually come out and say, hey, that 1999 paper is not accurate. There is no link between MMR and autism. But keep in mind, that's been a full decade at this point to allow that narrative to increase, certainly in specific areas. And at that same time, we are starting to see impacts to vaccination rates overall, which is now leading to the AMA and the AIP calling for the end of personal belief exemptions. And a lot of that is how people are getting around vaccine mandates in 2015 and 2016. And then you can see that in 2016, California, the first state to create this personal exemption in 1961, actually goes ahead and removes it in 2016. That brings us into, I think, the era we all remember, which is the COVID-19 pandemic starting in 2019, with the first vaccines available in 2020. And there is a lot of discussion and just really strong feelings at that point of the role of the government in vaccination and vaccination mandates. I think we all remember that pretty well. And now we're kind of sliding into 2025, where this medical governmental partnership that we kind of mentioned back in the boom era is starting to maybe dissolve a little bit, with the AIP and the CDC starting to have differential sorts of recommendations on vaccines. So that kind of brought us to a 50,000-foot view of things, but I do think it's worth taking a quick look at measles. This is the vaccine that kind of got the brunt of things from the anti-vaccination literature. And just to take a quick look at how things look over time, because it's also an interesting case if you consider that this really is a single person's lifetime. All of this came up in the baby boomers' lifetime. So if you realize in the early 60s, prior to the initiation of the vaccine in 1963, measles was a pretty common disease in the United States. We can see the immediate drop pretty much once we have a vaccine available. And you have a couple of spikes in the early 70s in into the early 80s, but by the mid 80s, the rate of measles is really pretty low. In the late 80s, early 90s, there are some pretty large outbreaks, predominantly in the New York State systems, that really bring in the second dose in the vaccine schedule. And then after that, you can see things really get reduced quite a bit. We get to elimination in 2000. When we now zoom in on this area below, you can see that although it looks really good up top, when we zoom in, we are starting to see the impacts of reductions in vaccination levels with a series of health advisories in 2008, 2015, and then more recently in both 2024 and 2015 with measles coming back up. Certainly not to the level that it was pre-vaccine, but it really does kind of lead us into a where are we going now? And Lisa, I'll hand it off. Yeah. You're on mute.
Thank you. So as Brenna just described, a lot has really happened in the vaccine space over the last 300 years, but really potentially the one thing that is the most concerning is this somewhat recent, but really rapid evolution of the vaccination landscape as it pertains to vaccine acceptance and hesitancy. And Brenna mentioned some of these things, but when you really sort of think about it, in less than 3 decades, we have really shifted from a place where you really had parents lining up and begging and requesting that their children be able to participate in the Salk polio vaccine trials, to where we are now, which is, where you saw, as Brenna mentioned in the last month, for example, the American Academy of Pediatrics, which historically has had this very long history of providing evidence-based guidance on vaccines and has worked collaboratively with the CDC and others to really harmonize vaccination recommendations, breaking with government recommendations, particularly as it relates to COVID-19 vaccination. And this shift can also be seen really in the sentiment around vaccine efficacy and safety, where you have a situation now where almost a quarter of parents cite vaccine safety and as adverse effects as an issue for their choice to not or to vaccinate against influenza. And almost 50% cite these same issues for COVID-19 vaccination. And so what you have going in parallel with this shift in vaccine sentiment has been really this parallel change in where and who people, but parents also, get their health information. And research now indicates that, particularly among parents, that their social networks are now a significant predictor of whether or not they vaccinate their children. And we will dive into some of that a little bit later in the presentation. So Brenna talked about the availability of the measles vaccine and the impact on outbreaks in the US. And given the more recent shifts in vaccination attitudes and the fact that, at least in the US, it's the start of the school year, we thought that these maps might really highlight some of these trends on MMR vaccination among children entering kindergarten. For those of you that are not in the US, and maybe some of you that are in the US, what I would have told you if I was doing this presentation yesterday would be that every state in the United States requires that children have 2 doses of MMR prior to entering kindergarten. However, yesterday, the state of Florida eliminated all vaccine mandates. So in order, and including those for children, and the requirements around MMR vaccination to start school. So what this means is that there are no mandates to start school, and I guess effective, I'll assume that MMR has been taken care of, but effective next year, you will have children entering kindergarten in Florida who may be not or under vaccinated for all conditions. All states currently have some form of medical and or religious exemptions. But interestingly, a lot of them do now offer this philosophical exemption. Brenna mentioned California pulling theirs back. But what you can see is that, prior to 1998, there were very few, if any, states that had philosophical exemptions in place. And what you had during sort of the more recent years is that you sort of see this interconnection where the number of states and the percent of states that allow these personal and philosophical exemptions increases, and you see sort of this sort of coinciding decrease in the number of states that reach sort of herd immunity at 95% for MMR or for measles in particular, where you had maybe only, you had fewer than 6% that fell below 90% during the 2009-2010 school year. And that number has now doubled to 14% in the most recent school year. And, interestingly, I know that you talked about sort of some of the influences, but you see that sort of between the first and the second graphic, you have situations where the rise of celebrity influencers that are advancing narratives around vaccines and vaccines causing, sort of undesirable conditions, particularly autism, happening. And then, of course, between that second and the third graphic, you have the influence of the COVID-19 pandemic and sort of the sentiments around how well that was or wasn't handled, also playing a role in the overlay in some of these numbers. So, making sure that scientifically rigorous information is available and easily digestible becomes even more important. And this is really where real world data can potentially have an impact. So real world data, when I say real world data, I tend to think of things like administrative claims or health insurance claims data, electronic medical record data. This can include information coming in from, that's collected by government agencies or is collected at labs, or you can even extend that to sort of wearables and things of that nature. But generally speaking, if we focus more on the more traditional real world data sources of insurance claims and electronic medical records, these data really reflect the actual healthcare visits, the diagnoses, the vaccinations, the timing of these activities versus what a person might report based on recall or impressions of vaccine efficacy and adverse events that you might get with surveys. And so real world data can really be a nice complement to vaccine survey research, which has been done for many, many years. And so with this in mind, I'll sort of transition to Megan and a discussion around some of the specific places, including some examples of where real world data can really augment evidence generation in the vaccine and vaccination space.
Okay, so Lisa talked a little bit about what those barriers to vaccination are with those current ones, such as those social networks that she talked about. But there are a lot of long-standing barriers that people have faced when trying to become vaccinated. And those can be broken down into three general categories of economic barriers, access barriers, and social barriers. So some of those access or economic barriers include socioeconomic things such as income, education, and employment. Access would include things such as lack of health services in your area, inability to travel for those services, as well as just having health insurance gives you access to those medical care. Finally, social, there is, medical distrust in the community that has historic roots in it, perceived susceptibility to disease versus those adverse effects of vaccines, and then just the misinformation around vaccine and adverse effects. So to talk a little bit more about the economic, there have been numerous previous studies looking at these factors and how they play a role in vaccination rates. For example, studies looking at the association between household income, economic status, and education have shown that people in lower income families are less likely to be vaccinated. So those below the poverty line, people in high parental education households have higher vaccine uptake as well. And then kind of getting into the workplace. So this can be multifactorial. So, a lot of workplaces require vaccination, and those places will often offer that vaccination at the work site. So by doing this, they're removing that barrier, as well as that insurance is provided by the employer. So an example of how real-world data can be used in studies of this economic barrier. Data from real-world studies can be augmented with SES and SUH data that can help kind of add to the information that real-world data is providing us. So for example, in the CHIEF study, Merative collected survey data from employees during the influenza season. So employees were required or asked to fill out surveys, one per month. And this included data on their influenza status during those months, household influenza status, and then as well as some beliefs on vaccines in their, whether or not they got vaccinated, cost of vaccines, those sorts of things. And what this study found is that employees reported between 4.8 and 13.5% of employees had influenza-like illness at some point during those survey months. So highest was 13.5, lowest was 4.8. Those employees also, 61.2% of employees had at least one child during that time report an influenza-like illness. So we can see that, employment is affecting whether or not people are getting influenza, but it's also affecting the vaccine is affecting whether or not they're getting influenza and then influencing their productivity. So employees who got influenza were more likely to be less productive because they were sick. And Lisa and Brenna, I don't know if you had anything else to add to this portion.
I think the other thing that is interesting here is that you often, and this goes a little bit to what we might think about sort of some of the social factors, right? Which is that it does demonstrate that, that there is an impact even when the employee isn't sick. I think the work demonstrated that there was a loss of productivity even when sort of someone else in the household was sick. So caregiver responsibilities associated with sort of influenza also have an impact on that employee productivity. And you can sort of think of the extension of sort of the value of the collective buying into the idea around vaccination and preventing vaccine preventable diseases, because there is this sort of social impact that goes beyond just sort of the individual.
Great points. Okay, so moving on to access barriers. Again, to remind you, these include things such as lack of health services, inability to travel, and then access to healthcare through that health insurance. And this is an area where there has been a lot of previous research, particularly in access in rural areas. So studies have found that children who live in rural communities and get their primary routine healthcare from pediatricians' offices, from family health practices, things like that, those offices are less likely to stock routine vaccinations in their clinics, and therefore people must go to secondary locations such as community health centers to receive those vaccinations. And by doing so, it is placing an extra burden on those families because they have to receive their care at one location and then get their vaccinations at that second location. sometimes having to travel far distances to get to that second location, where studies have found that if patients lived at least 10 miles or further from their nearest vaccine provider, they were less likely to receive vaccines. So just having that access closer to your house and maybe where you are getting your routine childhood visits would increase vaccine rates. Also, just as another point, health insurance plans usually cover all the recommended vaccinations at no cost. But kind of as Lisa said, there have been this sort of discussion around changing recommendations and changes to Medicaid. So that could potentially be a barrier to coverage once those, or if those recommendations change in the future. And then digging a little bit deeper into the influences of health insurance on vaccination rates, a study conducted by the MarketScan team looked at influenza vaccination status among family units in the MarketScan data during the 2022-2023 influenza season, and breaking out the fully vaccinated, partially vaccinated, or unvaccinated rates of the full family unit based on insurance plan. We saw that those patients with the more comprehensive plans, so these would be the plans where each encounter has a reduced cost, so there's just that maybe copay or no fee for those services, were the least likely to be fully vaccinated versus those with less comprehensive plans. So maybe those high deductible plans where you are paying more for your services were more likely to be fully vaccinated. And one explanation for this could be that those people with those high deductible plans or less comprehensive plans are more willing to become vaccinated to try to prevent those high healthcare cost outcomes. So getting flu, ending up in the hospital, really trying to prevent that to not have those health costs later. So we can see that even within insurance types among insured people, there are still going to be those differences in vaccination rates. So maybe cost is still a barrier, even if you are insured here.
Yeah, and Megan, I think this kind of brings in how a lot of these factors, although we're talking about them in fundamentally different buckets, that the economic bucket cannot really be fully removed from the access bucket, cannot really be fully removed from the social bucket, and that, even though everyone is insured, there are still additional economic factors that influence access to these sorts of services.
Yeah, exactly. They are all interconnected, definitely. And then I'll pass it back to you, Lisa.
Thank you. Make sure I'm not on mute again. So to sort of bring this all together, so the World Health Organization has listed vaccine hesitancy as sort of one of the top 10 health concerns. And we thought it might be interesting to sort of show, just based on a raw count of publications from PubMed, the amount of scientific literature that speaks to vaccine hesitancy and sort of what that looks like. We mirrored the years that we selected here, 2010, 2018, and 2024, to align with those maps that we showed previously around the MMR coverage of kindergartners in the US. And you can see that sort of that relationship where during the years where coverage was a little bit more comprehensive, the number of publications that reference vaccine hesitancy was quite low, and we're now in a place where that volume has gone up, hundreds of percentage wise has gone up. And the amount of literature that is speaking about vaccine hesitancy is now relatively high. The reasons for vaccine hesitancy are complex, and Megan just spoke about sort of the economic and access components, and these are actually factors that the World Health Organization's Strategic Advisory Group of Experts on Immunization, or SAGE, included in a vaccine hesitancy framework that they developed. The social influences on vaccine hesitancy, to my way of thinking, are particularly complex because they really include a very variable mix of factors. So it can include cultural and religious beliefs. It can include the availability and the ability to interpret health and scientific information. It includes personal experiences and feelings about health providers, health systems, and government policies. And so, with some of this in mind, I mentioned the WHO SAGE group. They proposed this framework that really looked initially at 3 categories to really look at the factors that surround vaccine hesitancy. And this includes complacency, which is really, think of complacency as not thinking of diseases as high risk and as vaccination is important. It included convenience, which were the practical hurdles like access and the economic barriers that Megan mentioned, and confidence, which is this lack of trust in vaccine safety and effectiveness. And what SAGE did with this sort of 3C model more recently was to really expand the model to what is now called sort of the 5 Cs. And this 5C model, some part of this expansion really includes more of these social considerations. And so the framework now includes additional factors that capture some of these social aspects, such as calculation, which is, an individual's preference for deliberating, and collective responsibility, which is I mentioned a little bit earlier, this sort of altruistic communal orientation idea. And they also expanded the term and the definition of convenience, and they expanded that to constraints so that it doesn't just include practical barriers like access and financial, but it also includes psychological barriers. So I will touch on complacency, which again is sort of really not viewing diseases as high risk and as vaccination as important, a little bit here. But even before some of the recent acceleration of vaccine hesitancy, public health surveys really indicated significant differences in individuals based on and their attitudes around the value of vaccination. And you can see this in this example, particularly when you were asking parents based on sort of parents who are opposed to compulsory vaccination versus those that support compulsory vaccination. And what these survey results really show is that more parents who oppose compulsory vaccination hold the belief that vaccines are given to prevent unlikely diseases. And similarly, more parents who oppose compulsory vaccination also believe that vaccination is for sort of non-serious diseases. And, you can probably in your mind sort of hear the echoes of things that you hear even now about, sort of the vaccination of children against COVID-19 and this idea that, children are healthy and they bounce back, or, we talked amongst ourselves about even sort of, growing up this idea of having chickenpox parties because it seemed better to, have a group of people get infected together and then sort of exit sort of this infectious disease stage without sort of really thinking carefully about the impact of some of these diseases. In this same survey, you can see as well that fewer in the group that oppose the compulsory vaccinations, fewer numbers of those individuals really believe that vaccines are even necessary to prevent certain diseases. And this is a space where you see sort of complementary medicine types of ideas sort of coming to bear. And so, some of this is really part of a good news, bad news scenario where the success of some of the vaccination programs during what Brenna mentioned as the post-World War II era really means that there are fewer people now that have firsthand experience or knowledge of the risks of many vaccine preventable diseases. And consequently, what you see is a shift of attention to be focused more on the risks or the perceived risks of vaccines and vaccination rather than on the risk of the infectious disease itself. And this is really, I think, what you're seeing here in the results for this survey. And so what you have is really in the absence of sort of a lived experience, you have situations where even parents can underestimate the threat to their child's health of contracting a vaccine preventable disease. So there are really many types of analyses using real world data that can be completed about the negative impacts. So negative impacts like hospitalizations, reduced productivity, which we talked about, increased medical costs, which we mentioned as it pertains to sort of the costs associated with getting a disease versus preventing a disease, disability and death. And so there's a lot of types of studies that can be done to look at these impacts, particularly around vaccine preventable illness. What I'm going to touch on here is sort of a more unusual analysis with the aim of examining vaccine coverage in families that have a high risk family member. These findings are based on real world data source in which family and household units can be linked together through insurance coverage. And that insurance coverage provides information not only about vaccination, so whether vaccination occurred, but it includes information about the timing, the sequencing, and then other information about diseases and procedures and things of that nature. And so what this analysis really reveals is that when you have families that have a high-risk individual in their household, that you observe higher levels of both fully and partially vaccination status. And so I really sort of think about this as, while not exactly the same as sort of that firsthand experience that people may have had 30 years ago, where they see children contracting polio or the effects of, measles. And so while it's not the same as that at all, but sort of the goal is to really, in this analysis, to see whether sort of experience with, sort of a high risk person can have sort of a similar effect in terms of the influence on vaccine decision making, and whether those results then could be used to target research. And so I think this is an example of sort of an interesting use of real world data that can complement public health initiatives and things of that nature. I will turn it back over to Brenna to sort of speak to some other situations and opportunities to really marry real world data, publicly available survey data, to sort of advance the narrative around vaccines and vaccination.
Yeah, thanks, Lisa. And I think we've touched briefly, but we've touched on how real world data can be used both to, sort of mirror what we're seeing in survey data, which I think is extremely helpful, because if you think about the way that surveys are done, it is a prospective sort of issue. You have to define all of the questions that you're particularly interested in asking before you create the survey, before you administer the survey, all of those sorts of things. Whereas real world data, because at least certainly in the context of claims, is being collected for other purposes, you really have this sort of full compendium of a person's healthcare experience that's not necessarily being biased by who's going to take the survey or what questions you thought of ahead of time. And it allows you to sort of extend your research questions in some of the ways that Lisa's discussed. What do comorbidities look like? What do costs look like? What do family units look like? But also to other questions as well. So in one example, we went ahead from 2018 through 2022, we went ahead and identified people that had a diagnosis of flu and went to look and see how many of them are getting antiviral prescriptions. Now, this is irrespective of vaccination, but I think we can kind of make the argument that it's very related because vaccines are the preventative measure, and then antivirals for flu would be coming in, and it's sort of the reactive measure. And we can see in the same way that we've been talking about changing attitudes to vaccination and changing utilization of vaccines over time, we see a very similar trend in antiviral prescriptions. And I would say it's very much focused around the COVID-19 pandemic, where there were a lot of discussions around public health and interventions in general. But you can see here that, you know, kind of extending that research question to something that we may not have thought of, a little bit tangential to vaccination, you can see that, you know, we're getting a notable drop in antiviral utilization over time, and that it's started to come back up a little bit since COVID, but we're certainly not at the point that we are pre-COVID. And this kind of allows us to ask questions around, is mistrust of vaccination extending to other pharmaceuticals? We might be seeing that in other areas. You know, getting back to Lisa's point about the concern about the risk of illnesses. Are people kind of saying, yeah, they have flu, it's fine, we're not going to do anything about it? And that also has then implications for other things that were mentioned around productivity and, you know, indirect costs of disease and societal impacts. The other thing we can start to do is start to understand maybe more holistic attitudes around vaccination through real world data. This is looking at individuals who did not get an MMR vaccine. So these are children that are 2 years of age who did not get an MMR vaccine. And what you can see here is that the belief around vaccinations does not necessarily seem to be absolute. And I'm kind of taking this as a heartening thing. No one's going to say that a 50% vaccination rate is good because it's not. But I would say it's good in that it's not zero. You can see that even though parents decided not to get their children an MMR vaccine, they did, upwards of 50% of them decided to get a diphtheria, tetanus pertussis vaccine. Nearly 50% of them got their children vaccinated for poliovirus. And what this is kind of leaving me with is that there is still hope and there is still room for conversations around vaccination and the importance of vaccination, and that these vaccines, it's not an all or nothing. It can be kind of had on an individual vaccine by vaccine basis, leaving that room for conversation. So with that, I'll turn it back over to Lisa to finish up.
So, and I think it's a nice place to close, right? Which is around the place where there's still an opportunity for the conversation. So, I'll return quickly to an element that I sort of skipped during the previous slides, and that is the challenges around vaccine communication and the volume of misinformation around vaccines and vaccines preventable illness and healthcare providers, and that this misinformation is really amplified by the ubiquitous use of the internet and social media. And when you think about that, you know, research indicates that 43% of all health misinformation that is available on the internet and social media, 43% of that relates to vaccines. So of all the things in the health sphere that is miscommunicated, vaccines is really sort of a gigantic pot of misinformation. And this is particularly problematic because, you know, I mentioned earlier about parents using social media as their sort of primary source, but there is research that indicates that among individuals where the internet is if they cite that as their primary source of vaccine information, that they are in fact more likely to refuse or delay vaccination. And so the idea of sort of identifying the places for hope and leaning in to how we can use real world data to battle misinformation is really key. And, you know, knowing this, you know, the idea to use these kinds of data to continue and maybe even accelerate the generation of robust scientific evidence that is maybe not only presented in peer-reviewed journals, but packaged in a way to make it really easily digestible by lay people, is sort of maybe a takeaway and a homework assignment for all of us moving forward. I borrowed this, I paraphrased this from something that I read, and I apologize for not having the citation, but I thought it was really a good way to sort of end our conversation before we transition to questions, which is really something that I think we all probably agree with and understand, which is, science is complicated and messy, and combating infectious diseases has become a battle of information and ideology more than sort of the race to innovation. And so our role as data scientists is really become much more critical than maybe even bench scientists like yourself, Brenna, as we think about sort of how to approach vaccines, vaccine hesitancy, and things of that nature. So with that, I will thank everyone for joining our presentation today, and we will skip down to see if there are some questions. So we have a question here about how generalizable vaccine coverage is using sort of the data source that we cited, the market scan databases, compared to what we might observe in the general US population. And I don't know, Brenna, if you want to take a stab at that one.
Yeah, sure. I can do that. So the databases that we used were commercial and Medicare populations. The commercial is predominantly employer-sponsored insurance, which is a large proportion of the insured US population. The Medicare population is predominantly derived from former employees who are getting their Medicare through their former employer. So it is going to be sort of more reflective of Medicare Advantage, Medicare supplemental plans. But it is a generally generalizable population, certainly for the commercially insured population. There are also Medicaid-related databases as well. We didn't necessarily show those today, but they are available. So I think really, and the point of this question is, although generalizability always needs to be considered when looking at real-world data, it does provide some robust understanding, and with the caveat and the need for interpretation of which populations you're looking at.
Yeah, I always think about it, Brenna, as having access to health insurance is in fact sort of a fairly substantial barrier, but in some cases that is it sometimes helps, if you will, with these types of analyses, because to some extent you've eliminated a barrier, one of your confounding variables, access, in some ways. But I also think about sort of the populations that are represented. You think about large self-insured employers, and probably for many of you, you work for a large self-insured employer if you're in the US, and that population is going to include sort of everyone in the employment spectrum. It's going to include your part-time custodial staff, all the way up to your C-suite individuals. And so even though there is this element of sort of insurance availability that is sort of standardized, if you will, across these populations, you still do have a very diverse population in terms of physical location, clinical and demographic characteristics, and financial situations. So another question is around, so if immunization information, particularly in the US and other places, is already available through the government, what does using non-government, real world data really add to that? And I can go ahead and start, which is, Brenna mentioned things like sort of the ability to, not be, tied to sort of a priori questions that may have been developed for a survey. Obviously, you're not subject to recall and things of that nature. But the thing that I think about is that the benefit of real world data is that it it is not self-reported. And so particularly when we're thinking about vaccines and sort of people's ideas about, sort of the risk of vaccine preventable diseases, or sort of the amount of adverse events and things of that nature, the use of real world data is then, focused on what really is observed, and not, perceptions and feelings and things of that nature. So I think it really complements. I don't know, Megan or Brenna, if you have anything to add there.
No, I think that really covers it. Maybe the one thing I would add is the really nice piece about especially real world data that is more complete is that you really can, as I said before, just extend these questions into things that may seem not necessarily related at the time, but you can extend it into understanding what people's regular healthcare resource utilization looks like and how that impacts vaccination. You can start to link in other data sources if you wanted to. So you could start to link in more economic databases. You could link in patient wage. You could link in social determinants of health through zip code or things of that nature. So I think the nice thing about real world data is it just, because so much of it is out there, you can start using data in ways that you wouldn't necessarily have thought of initially to understand vaccination and understand what's going on in people's lives from their healthcare perspective.
Yeah, I think there's the cynic in me would also say that if you think back to that slide where we looked at the vaccination rates from the National Immunization Survey and then from the market scan data, one of the things that did is it does provide sort of validity to some of the information that is being generated by government sources, and perceptions of government involvement is one of the things that sort of one of those social concepts that was mentioned, and so there is a, regardless of what you think about commercially available data, it is both nice to have it to be sort of as a validity check, but also in circumstances where the government may be pulling back on what it's generating and what it's making available, commercially available sources can sort of be a fill the gap where those gaps exists. Another one, and I know we just have a few more minutes, is sort of like we focused on a lot of childhood vaccines in this presentation with the idea that it's fall and kids are going back to school. But like, Brenna, Megan, would you say that the role for real world data for adult vaccines is the same as it is for childhood vaccines that we talked about today?
Yeah, I can take that. So I would say that it is definitely similar. And in some cases, you could maybe make the argument that real world data is more important in adult vaccines, just because a lot of those adult vaccines, such as shingles, are kind of more about personal protection versus creating that herd immunity that we need with the MMR. So they're tracked less by the government just because we don't need to reach that herd immunity. So through using that real world data source, we can kind of track those personal protection vaccines, as well as a lot of those vaccines are the ones where, if you qualify for them, if you're over 65 or if you have that underlying health condition. So we can look at people with those underlying health conditions by linking their claims to see if the people who are recommended to get the vaccine are actually those adults that are getting it.
Thank you. So I think with that, we will go ahead and thank people for participating. I will send it back to you, Alex, for final comments.
Brilliant. Thank you all so much for your presentations today. And yeah, it was some really interesting insights. And thank you to the attendees as well for joining us. Tomorrow, you'll receive an email to say how you can access the on-demand version of this webinar, or you can access it through the website arenainternational.com/events. Please use the related content box to access any additional resources. and you can continue to ask questions and interact with the widgets, as the on-demand version of this event will remain interactive. The speakers can also provide you with a written response directly, as well as those who've submitted questions that we didn't have time for, unfortunately. Thank you once again, and I hope to see you on another webinar.